Good afternoon. I'm Laura Lucas, the Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm here to introduce Mr. Dan Todd, who's Principal of Todd Strategy, as our expert presenter for this third e-course in the series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO, who will discuss Washington perspectives and their implications on such therapies as immuno-oncology. As you may know, ICLIO was founded in 2015 and is the only initiative that prepares multidisciplinary cancer care providers for the complex implementation of IO in the community setting. ICLIO is an institute of ACCC, and we encourage you to visit our website at accc-iclio.org to browse all of the resources offered by ICLIO. And also save the date for the national conference on September 30th in Philadelphia. For today's e-course, I'm pleased to introduce Dan Todd. Again, he's the principal of Todd Strategy Consulting, which is a firm based in Washington, D.C. He provides legislative and regulatory strategic guidance and advocacy for healthcare stakeholders impacted by federal healthcare programs. Prior, Mr. Todd was a senior healthcare counsel for the Republican staff of the Senate Finance Committee, the Committee of Jurisdiction for the Medicare and Medicaid programs. His areas of responsibility for the committee included the Medicare Part B and Part D programs, which includes division, medical device, diagnostic, and biopharmaceutical issues. Mr. Todd also served as a special assistant to the Office of Administration at CMS. While CMS, he worked on Medicare Part B and Part D again, and the implementation of the Medicare Modernization Act from 2003 to 2005. And now for a few housekeeping notes before we kick off the webinar. Please feel free to submit any questions that you may have for our presenter by typing in the box on your dashboard. Questions will be posed to Mr. Todd at the end of the presentation, and the webinar will be archived and available on the ICLIO website. Now I'll send it over to Dan Todd to kick off the webinar.
Thank you, Lorna. Thanks everyone for having me today. Before I kick it off, you heard in my bio that I was on the Republican staff of the Senate Finance Committee. The Finance Committee has jurisdiction over the Medicare and Medicaid programs, and I had the opportunity at the time to work on a bipartisan bill now known as MACRA, which has spearheaded a lot of the payment reforms that we're going to talk about today. So to the extent that folks also have some questions on that, I'm happy to answer framework questions or what the heck we were thinking in Congress when we put this 180-page bill and now 900-page regulation on the backs of providers. Because I'm an announced Republican, I'll start with I'm a dying breed of Republican. Now that Donald Trump is the presumptive nominee, I am firmly in the establishment, and there's none of us left. So with that, I'll start off with a little bit of the environment and go through some of the more specific issues and expectations from Congress, the administration, and the election. So, Lauren, you go one next slide. So, current environment. We are now 6 years post the Affordable Care Act, otherwise known as Obamacare. It continues to be a lightning rod of politics in Washington. But I do think you're starting to see some shifting in the ground politically on where I think we're going to go in the next 18 months, 2 years. Of note, the uninsured rate is now down to 9.1%, down from 16% pre the Affordable Care Act. That is the lowest number on record. Premiums on less positive note, premiums for family have increased 27% in the employer market. And the average deductible for employer coverage has increased 44% to $1,318. This year, you will see a lot of press and a lot of political hay made over double-digit premium increases in the individual market. Just last week, Blue Cross and Blue Shield of Texas requested a 59% increase. Highmark in Pennsylvania requested a 48% increase. So the market is still very much trying to find its stable footing. And you increasingly see on earnings calls some of the big players talking about removing themselves from that market. Additionally, a big part of the Affordable Care Act, as well as bipartisan efforts before and after, have been efforts to move away from so-called volume and fee-for-service-based arrangements to value or risk-based arrangements. That is probably most publicly revealed in the alternative payment model referred to as the Medicare Accountable Care Organization, or the ACO. Currently, there are 477 participants in the Medicare ACO pilot. Additionally, in the Affordable Care Act, you've got some political liability for the Democrats and some financial liability for the government with 10 out of 23 co-ops, which were the sort of the nonprofit structures, health plans, going out of, or 10 of 23 remaining, 13 going out of business, going belly up. We've all read in the paper the concern about high-cost drugs. This is something that's going to play itself out for the remainder of this year and likely expected within the beginning part of the next administration. And another issue that is increasingly an issue for policymakers is provider and payer consolidation. We've certainly seen the payer consolidation play itself out rather publicly with some of the bigger acquisitions, and a little less so on the provider front, but equally as concerning as policymakers are increasingly aware of acquisition and the long-term costs that will drive for the Medicare program. A lot of change in the last 6 years, a lot of movement that seems to be hitting a tipping point, and so we'll talk a little bit about that. Next slide, Laura. So one of the questions you get is how's it going to be different in the next administration? The one thing I'll say is normally in Washington we would say that this is a lame duck period for an outgoing administration. I don't think anyone's told that at this administration that they're lame duck. They've been extremely active through regulation. They have put out the proposal for MACRA implementation for payment reform. They have put out this Part B demo for Part B drugs through the Center for Medicare and Medicaid Innovation, and they continue to be extremely active, and I think we'll continue to see activity this month with the proposed rule for hospital outpatient payment and the physician fee schedule, which I think will also have some policy priorities for the administration contained in them. So definitely going to be a very busy June going into a July and August comment period. So one of the things that we can look at is the policy platforms of the two likely nominees from the parties. We can go a little bit into it as a editorial note. There is not probably to too many people's surprise a little bit more detail to the Clinton campaign platform than to the Trump campaign, but we have. I think we can expect that the Trump campaign will build out its platform over the coming months as they staff up, and I think we can look for that. But in the meantime, we can look to public statements there and understand where they're going. Real quick, let's start with the Affordable Care Act. The Clinton campaign has positioned themselves as defending it and trying to build on some of the cost controls that are contained in it. I think they see as coverage has largely been accomplished through the ACA, cost has not. That's obviously a substantial downside risk in the coming years for providers as the administration, the incoming administrations try to deal with rising costs, particularly with the baby boomers retiring. With drugs, there's an increasing focus on drug pricing, and you'll see a sort of a growing consistency on the left or on the Democratic circles that either talk about mandatory rebates, march-in rights to invalidate patent holders, and an effort to take away pricing exclusivity for certain biologics. I think you're going to continue to see those as driving issues. They highlight protecting access to women's reproductive health care. Specifically, I'm not sure exactly what that is, but that's certainly a key point and a key constituency in the campaign. Premiums, I think we can expect over the next 9 months to really drive a lot of the discussion, and I think where you'll see a lot of activity, almost regardless or irrespective of who comes in. The exchange market will be something that the next president will have to deal with. And then finally, on the Democratic side, it's incentivizing the Medicaid expansion for the states that have held out so far. That can either happen through granting waivers through CMS and through other means. But I think regardless of side, I think you're going to see the Medicaid expansion and getting these last folks on board as a key priority. And then finally, the Clinton campaign has renewed the call for a public option or a Medicare for all. Again, this is something that was a hot topic on the left during the Affordable Care Act, and this campaign has been brought back. As we go to the other side of the ledger, The Trump campaign has said that they will repeal Obamacare and eliminate the individual mandate. One of those things is probably possible, one is not. Eliminating the individual mandate has been weakly enforced to begin with, and it remains unpopular. However, repealing Obamacare, and we'll get into this a little bit in the following slides, but when you have the House of Representatives and the Senate also up for re-election, a full repeal of Obamacare is likely going to require 60 votes in the Senate, and it's unlikely that President Trump would have that in the event it's President Trump. It is likely that he probably will hold on to the Senate, but if he does take the oath of office, he'll be well short of a 60-vote mandate in the Senate. He has also highlighted, and this has been a key party platform for the Republicans, allowing the sale of insurance across state lines or portability. He has advocated for tax deductions for insurance premiums at the personal level, not just at the employer. He has called for a more robust health savings account that will enable accumulation of the sum over a lifetime without penalty of death. So that's a big one for both employers and some of the think tanks on the right. And then finally, an issue that really is bipartisan and we're seeing play out more aggressively at the moment in state capitals than in the federal government, but price transparency for providers. Where Medicare has put its toe in the water on this, both with Hospital Compare and most recently with Physician Compare, and the drug dashboard that was released last year. But it's not necessarily in a user-friendly tool yet, and I think you've seen more activity on the states, but I think you're going to see this as a key policy effort, probably on both sides in the coming year. Finally, on Medicaid, there's a push on the Republican side and the Trump campaign to block grant Medicaid. This is an oldie but a goodie. Been around for a long time on the Republican side. You'll also hear this as a version of per capita caps. Per capita caps for states operate like a bundle or a block grant. Interestingly, per capita cap originally appeared in one of the first Clinton administration health budgets for President Bill Clinton. So that might be something that could be talked about as a potential negotiation for healthcare savings in the coming years. The Trump campaign is also addressing drug pricing. He has said in debates that he'll save a lot of money. They call for removing barriers to entry of free markets and allowing the importation of drugs from ex-US, and then finally a fairly substantial divergence from what's happening in a lot of the states with heavy immigrant populations, but to stop providing health care to illegal immigrants. These are some of the issues that you're going to hear talked about over the coming months, and are very likely to be dealt with in a first 100-day priority for either administration going forward. Next slide, Laura. So not only do we have the enchilada with the presidential race, we also have the substantial undercard. The undercard here is, some are talking about the potential that the House of Representatives could flip from Republican. I think that remains unlikely, though Leader Pelosi today did say that if the election were held today, that they would take the House. I don't know polling that well, but I think that because of the way districts are drawn and the largest Republican majority in House history, I think that they've got to have quite an election to be able to achieve that. I think that's going to be a surprise. I think you'll likely see Speaker Ryan continue as Speaker in next Congress. The key fight is in the Senate. There are 34 seats up, and the Republicans are playing defense, I believe, on about 21, 22 of them. It's a tall order for them. There are fairly substantial toss-up states: Pennsylvania, Ohio, Florida, Colorado, New Hampshire, that are all up, as well as Wisconsin. So you're going to see a heavy fight for the Senate. And right now, it really is anybody's guess on whether the Republicans maintain control or whether incoming Democratic leader Chuck Schumer from New York will take the reins from a retiring Harry Reid. So I think that it's going to be a key undercard that obviously, with the presidential, has a fairly substantial implication on the Supreme Court and what happens at the very beginning of the next Congress. Next slide. So getting into the details a little bit on policy, industry consolidation has increasingly become an issue. Part of this is because of what's happening in oncology with community versus outpatient clinics and the growth of outpatient spend compared to clinics and the attention that the 340B drug discount program has taken within policy circles. We call here attention to, one, the consolidation within hospitals, and then as well as the consolidation of physician and medical groups. The reason this is a salient point is that hospital acquisition of physician practices or community setting is typically a 30% increase in cost for the Medicare program. The long-term projections from the Congressional Budget Office are saying that the Medicare Trust Fund is around $40 trillion in unfunded liabilities. That is a bigger number than I think many of us can count. It's an awful lot. So that is why savings like this or policies like this have increasingly drawn attention. We can go to the next slide. So here we can talk a little bit about the payers. Some have said that this is a direct result of the Affordable Care Act the challenge to the risk adjustment for taking on sicker and older patients than I think they expected. I think regardless of the cause, clearly consolidation in the market is something that is likely not going away. This year, you've seen a lot of attention to Aetna and Humana and Anthem and Cigna. These are two giant mergers. I think one looks like it's going a little bit smoother than the other. But I think the key question will be whether this happens before the administration changes. We have seen this Federal Trade Commission be a little bit more aggressive than FTCs in the past and Departments of Justice in the past, and whether that's with regard to hospitals or other consolidations. But I do think that it's a taller order on acquisition than has been in the past. I'll say politically, I would not expect Republicans to weigh in on these big mergers. They will typically be more hands-off in the business environment. I think you'll see increasing concern from providers and from Democrats than you will from Republicans. Though I think Republicans will use this clear as a point. I don't know what you mean by. Sorry about that. We'll certainly see this is a point that the health insurance market is not healthy, and will likely point to the Affordable Care Act as the root cause. Next slide, and we can talk a little bit about consolidation with providers. So this is where there's been a lot of activity within the last 9 months. So last year, when we were working on a bipartisan budget in November, they took action on what's now referred to as Section 603 in site-neutral payment, and this will likely be in rulemaking in the next couple of weeks, but effectively stops the growth of off-campus hospital outpatient departments. And effectively, whether it's acquisition or construction, effective January 1, 2017, those facilities will no longer be able to bill at the higher hospital outpatient rate, but will have to remain at the lower physician fee schedule rate. I think the sense here is that there's some key policy issues, whether 340B drug will also be allowed to extend, or whether that's also shut off. And then there's also a current fight in Congress that seems to be getting some momentum, where some of the cancer PPS hospitals have argued for effectively a carve-out of the under construction that will allow them to continue to grow, based on how far along they were in the construction process. That made it out of the Ways and Means Committee. It is expected to be likely on the House floor in the next session, whether perhaps as early as next week. but could slip into July. But I think the expectation is that modification will make it out of the House of Representatives. And in seeing what kind of vote you get, if it's a big vote like 400 members, which would be a big bipartisan vote, that puts a lot of pressure on the Senate to take action. At this point, it's unclear. It's unclear where the Senate is on this. We certainly have some proponents over there, but I think you'll start to see within your facilities and practices greater discussion of this as it moves into the summer and the fall. With that, we can move to the next slide. One of the big priorities of this administration and of bipartisan members in Congress, really starting pre-ACA, picking up steam during the ACA, and continuing momentum after the Affordable Care Act, is this this value transition. Following negotiation and reporting out of the physician payment reform, now known as MACRA, out of the committees towards the end of 2013, when it became apparent at the time that we weren't going to pass the reform, the administration looked to what they could do administratively to codify much of this. A few months before Congress passed the MACRA SGR repeal bill, they came out with a stated goal of moving alternative payment and hitting a sizable portion. I think what happened here is that as we developed our physician payment reform in Congress and talked with experts and health plans, there was a realization that while folks certainly had been talking the talk on payment reform, the specifics were not quite there yet. And to the extent that the private sector was moving faster than the government, neither were moving all that quickly. And so with these stated goals, this was an effort to put a shot in the arm for CMS to make a transition and to get to a tipping point. They recently announced that they've achieved their first goal of 30% about a year ahead of schedule. They're looking to achieve 50% of value-based alternative payment models in 2018, and they appear to be on target to achieve it. The second goal is increase the amount of Medicare fee-for-service payment tied to quality, 85% in 2016, 90% in 2018. These are really big numbers. They are numbers that appear daunting on the face of it, but when you think about some of the quality programs that have been in existence, whether it's physician quality reporting, value-based modifier in the physician setting, or some of the value-based hospital payments, and some of the skilled nursing facility payments that are now tied to quality, perhaps this isn't as daunting a goal as one would originally think. Next slide, please. So real quick, we can talk a little bit about what's gotten an awful lot of attention and sucked up an awful lot of oxygen in Washington is this proposed Medicare Part B drug demonstration. This highly controversial, obviously hitting oncology particularly hard, also hitting other specialties, but hitting oncology and community oncology particularly hard, is an effort by the administration to try and get at drug pricing. They have done it through the effort of lowering the ASP price and expecting to see the average sales price, expecting to see a change based on this change in reimbursement to lower cost therapies. Again, this has been highly controversial. Received nearly 1,000 public comments on the Federal Register, many negative comments. It impacts 75% of Medicare Part B payments, nearly sizable majority of community oncology. It has received a lot of attention from Congress and stakeholders alike, and they are now in comment period. And I think the real question is, where do we go from here, and whether they achieve their very aggressive time frame of starting this new pilot in differential payment in this fall, or whether they are, based on the size of comments and the controversy around it, whether this gets punted in some way. The administration was very aggressive in public outreach in the beginning of the release. Since the comment period closed, they have moved to a quiet period, as is appropriate and legal. and I think that we'll expect that over the next couple of months as they review comments. Happy to take more questions on that as you have them. Go a little bit to some of the reception on the next slide. Strong opposition, strong opposition. You have from the Community Cancer Alliance, this is about the government inserting itself and stating that physicians are not correctly treating patients and that it knows better. Strong original statement from the three big chairmen. That would be my old boss, Chairman Hash on the Finance Committee, Chairman Brady of the Ways and Means Committee, and Chairman Upton of the Energy and Commerce Committee, the three committees of jurisdiction for Medicare. CMMI's proposed experiment on seniors stands to limit access to the critical care of the sickest Medicare beneficiaries rely on, as well as disrupt how healthcare providers serve patients. One, I think that in the rollout, CMS referred to this as an experiment. I think that it's safe to say that probably is unwise media training at the very least. But this has gotten an awful lot of attention. There were 4 congressional letters. There strong letter from all the Republicans on the Senate Finance Committee. Strong letter of inquiry from many of the members of the Senate Finance Committee on the Democratic side, and a call for withdrawal from the Republicans in the House of Representatives. So this is very politically charged at the moment. And as again, we're in comment period, and there's a lot of rumor mill, but some interesting things to talk about there. Next slide. To the extent that they do finalize something in the Part B demo, and oncology is protected, it'll be in large part towards the oncology care model. The oncology care model is a demonstration also out of the Center for Medicare and Medicaid Innovation, one that was in development for nearly 3 years and negotiation with stakeholders, with oncologists, patient groups, and CMS. And the timing really couldn't have been worse here. The Part B demo came out in March, the drug demo proposal came out in March, and contracts for the oncology care model were supposed to be signed, executed in April. Obviously, this put a lot of pressure on the oncology community. CMS is accepting comment on whether it's appropriate to carve out the oncology care model. Effectively, what this is a model that will, I think they believe, get at some of the unnecessary hospitalizations that occur from side effects within chemotherapy, but it pays a penny per month, $160 payment for 6 months, as well as some incentives for performance to a practice. It's a 5-year duration. You can accept downside risk in year 3, and sort of the gem. The gem for CMS is that it encourages a private-public partnership with private payers as well, sharing data. They believe very strongly in this. I think they were very excited about it. I do think that the Part B demo provides some complications for them and for their success here, as well as for their efforts in tracking in terms of effects. So this is one where pay very close attention to the interaction between the oncology care model demo and the Part B demo. Next slide. We can talk a little bit about the Institute for Clinical and Economic Review, ISSUR. ISSUR is not all that popular right now between patients and manufacturers. It's a health technology assessment board largely made up of payers, and they are now in the business of evaluating drug effectiveness. They've been in business for a while. Medicare has used them for a while on technical assessments on the coverage side and for evaluation. They have increasingly gotten involved in the cancer space. Most recently, last week in a public forum on multiple myeloma. In phase 2 of the Part B drug demo, they talk about some value transition goals and specifically call out roles of entities like ISSUR. It's certainly something to pay attention to as ISSUR continues to get support both from private sector payers, but increasingly from public sector as well. So we'll call that out, and with that, that's the crux of my presentation, and I'm happy to take questions from anyone on. Thanks for having it.
Great. Thank you so much, Dan. And yes, we do have a couple of questions to shoot your way. Excuse me. So how likely is it that the next administration continues all of the Obama administration's value transition efforts?
Lauren, it's a great question. You know, I think when over the last couple of years, and I think MACRA has contributed an awful lot to this, a lot of the efforts from so-called volume to value or alternative payment, I think before the Affordable Care Act were largely bipartisan. I think they were made fairly partisan and political in the context of the Affordable Care Act. I think that over the last several years, last 4 years particularly, that has started to thaw, and increasingly because of the efforts on the private sector as well, these efforts are likely to continue in a bipartisan manner. One of the things that I think that you'll see is that providers sort of across the board are now looking towards alternative payment as a way of potentially getting increased payments in the program, and with that comes advocacy around the efforts. So whether it's bundled payments with appropriate growth metrics or quality metrics that have the opportunity for providers to differentiate themselves and get additional revenue, because they're going to be calling for these things, I think it puts a lot of pressure on Congress to continue efforts. And it really does seem like there's increasing alignment among payers, so my expectation is that it continues.
Great. Great, thanks. And then some, we've heard from some of our members' perspective, it might seem like consolidation is happening everywhere. Do the policymakers in DC actually understand this, or are they even encouraging it?
I certainly don't think that they think that they're encouraging it, but certainly policy probably encourages it. They're certainly aware of it. I think the sense is, I think the effort from those of us that are in advocacy positions need to make sure, and our fight will be, that to the extent that consolidation and consolidation efforts lead to payment changes, that we don't just go to the least costly setting or the lowest price. That in some cases, site neutral might be appropriate, but that might not just be the lowest payment. You might actually have to pay more for a site neutral payment that accomplishes multiple sites. So those are the conversations that I think are going to happen. But there remains intense pressure to find savings within the Medicare program, and because of that, consolidation payment rates around the consolidation issue are not going to go away.
Great. All right. We have another really great question that's come in. So is the restriction on building hospital outpatient facilities also restrictive on existing building expansion?
So no, it's about, so this is one of the challenges, and we will find this out in the regulation, but the statute now talks about new facilities that are under construction. So that, if you're expanding, my understanding is that you can, and if you're already receiving an outpatient rate, you'll continue to receive an outpatient rate.
Okay, great. And then from the ISSUR evaluation model, you mentioned to the one ASCA release yesterday, there seems to be a number of voices offering ways to define value in the industry. Is one of those likely to rise to the top, or do you think there'll be enough competing options that will cause the government to step in as the final arbiter?
I don't think that the politics are there for the government to step in as a final arbiter. I think that this is an incredibly, particularly in the oncology space, folks on the phone here know it better than anyone, increasingly personalized. I think that there really seems to be a disconnect in some of our policy conversations where on one hand, we're talking about precision medicine and personalized care, yet our payment policies continually try to plus up into a bundle or a macro type environment. I think that personalized is ultimately going to end up winning here. But my sense is on a lot of these value frameworks, it's certainly contributing to the dialogue. I don't think it's going to be a one-size-fits-all, but I do think to the extent that they do drive a discussion between patients and their physicians, I think that's probably a good thing. I think that the challenge will be to keep whether the government or other payers from using a one-size-fits-all with these, because frankly, that's not to the benefit of patients.
Okay. All right, and I think we have time for about one more question. So going back to the OCM and to MACRA, which I know you had a hand in. In MACRA, only two-sided risk OCM participants are eligible for advanced APM track. Should our folks be concerned, or our members? And how do you think one-sided OCM participants will fare in MIPS?
Two great questions. So one of the challenges that I think we have with alternative payment, and this goes to some of the philosophy of the legislation and some of the constraints we had because of the Congressional Budget Office. The entire package of physician payment reform cost about $150 billion, $150 to $175 billion. We knew that we couldn't really trip into a bigger number, that there's only so much the system could swallow in a bipartisan manner. Because of that, because of the hole we were digging out of from the SGR, the alternative payment section was a relatively small portion. It was roughly 7% of the entirety of the bill, so less than $10 billion. When we write legislation like this, it's typically in negotiation with CMS and the administration. So they were well aware of what our targets were and what our parameters were with the Congressional Budget Office. I think they finalized. Largely consistent with what congressional intent was. Now, that doesn't mean that that through advocacy, folks won't be successful at getting their model adopted in order to qualify for bonus payments. And I think that's where a lot of effort will be spent, and a lot of that is going to be on the policy side of developing the data and the metrics to be able to qualify. With regard to the MIPS program, I think that my sense is that one-sided OCM will likely do very well in MIPS. MIPS is a dynamic system where providers will be scored against each other, and I think the sense is that if you are in an OCM, you're likely doing things that not every other provider is doing, and you will likely fare pretty well. Additionally, money was thrown into the MIPS program to make it to create more winners than losers. So I think it's going to be very difficult to imagine that OCM participants wouldn't fare well. Obviously, time will tell on that, and we'll learn a lot more in the coming months. But my sense is that that you're doing a lot of the things in that OCM that gain points in the MIPS system. Lauren, you still there?
Sorry about that, I was muted. Well, thanks, Dan. And I did just want to kind of connect the dots here. Since this is an ICLIO webinar, would you be able to kind of make the connection for us as, what does all this mean for the IO biologics that are coming out and are in development and that will be coming to market?
Well, great point. I think with IO, I think one of the challenges, I think we've seen incredible growth and acceptance, and I think that both for patients and providers is great. I think that one of the challenges will be as Medicare wrestles with alternative payment, and you look at things like indication-based pricing and episodic-based pricing, and as they move to more care models that pay upfront as opposed to the service, the challenge for IO is going to be cost and access, and increasingly there has to be an education both from manufacturers and from the providers within CMS. They remain very interested, and certainly I think the folks on the phone are far more experienced with this than the Medicare program. But as these programs roll out, they are undoubtedly going to have a tremendous challenge with some of the costs as they have sticker shock like other payers. And maintaining access within the community is going to be a key priority over the next 2 years. All
right. Well, thank you so much, Dan. And again, thanks for everyone for participating. The presentation was great, very engaging, and thank you so much for our audience for participating today. Both the webinar and slides will be available on our website, which again is ACCC-ICLIO.org, and we should have it up before the end of the week. All registrants will receive an email with the link, so if any of your colleagues missed it, you can forward the email to them, and so hopefully they can check it out as well. And also, please register for our upcoming ICLIO conference. It's scheduled for September 30th, and it's going to be in Philadelphia. And a lot of the conversations that we addressed today with Dan will be continued at the conference, so please sign up. All right, well, thank you so much, everyone, and please enjoy the rest of your week.
Thank you, Lorna.